Hi, this is Elliot Fishman, and welcome to part 2 of our talk on cinematic rendering. And I finished part 1 with this slide talking about image creation. At the end of the day, any 3D imaging, the truth is any imaging really depends on the quality of images you create. One of the things about cinematic rendering, and one of the reasons people do not use it, they feel it's very difficult to create images. Our feeling is, yes, it's difficult when you get started, but there's a learning curve, and once you get past that curve, you can do very well. Also, our experience is we use presets. So I have presets, and I'll show you in a moment, for pancreas and liver and lung and intraluminal, all sorts of presets. And it's creating these trapezoids to optimize this image visualization. The presets speed up the process. Most of the time I could start with a good preset, then I just need to adjust for a specific case just a couple seconds, so maybe I'm 90 to 95% of the way there without changing the preset, and the last 5% really makes the image as good as it can be. So we'll talk about that. And so if you took a look at my screen, you would see a lot of presets. Here's just 3 of them. And if you open one of the presets, say thoracic aorta cinematic, you'll see this trapezoid, you'll see the curve that we develop to make it really work well. And I create maybe 1 or 2 new presets a week, sometimes less, because I have probably close to 200 presets now. Sometimes I come up with new presets, like this past week. I came up with this really good preset for looking at details of vascular mapping. And I'll show you a few of the cases I added just minutes ago. But again, you want to have these presets which work well. Depending on the patient, obviously patient size, patient fat planes, the injection rate, many things, the type of tumor. So for example, I might have 10 to 15 different presets for pancreas. Not that I use all of them on any specific case, but I have them available. And here's just some more examples of that. So a key to getting started is get presets. Siemens provides, and any vendor you have provides some presets, but I think you're going to have to do work to get the optimal presets for your own practice and for your own applications. So some common questions people ask me about cinematic rendering. First of all, there are no specific protocols for the data sets. You just do your usual protocols. Now, one thing I typically don't do, I don't do reconstructions from the high-res images. That means with the high-res filter. And that's true with any 3D because images tend to be very noisy. There are some exceptions, but typically we use the standard or soft tissue kernel. We do the processing by the radiologist, and I can do an average study with filming in under 5 minutes and probably under 2 minutes if I didn't think about the fact that I'm also taking slides that I want to use for presentations. If you think about applications, there are way too many for me to review. On the GI, you can think about stomach, small bowel, colon, pancreas, liver, and spleen, to mention just a couple. Geo applications ranging from the kidneys to adrenals to the bladder. Vascular applications continue to grow, be it cardiac, be it the aorta and iliac vessels, or runoff studies, or the mesenteric vasculature, or doing vascular mapping for preoperative planning, whether it's various organs or various tumors, and of course musculoskeletal, particularly trauma, but also oncology, and preoperative planning for reconstructive surgery. Now, just a couple simple examples to show you. This is a patient, we were looking for tracheal stenosis. There's a little bit of irregularity of the trachea, but there's the axial and a midplane sagittal view. Nothing very special about this technique, nothing very special about the images, but look at the detail I get with the cinematic rendering, submandibular nodes, the vessels, the muscle, the bone, and the soft tissue. And depending how I render, what I make more opaque and what I make more transparent, you could see different things within the data set, but look at the details of the things you indeed are able to see. And of course, if I looked at this with motion, one of the things to remember is when I show you static images, that's me taking a picture. When I'm looking at the images and I'm analyzing a study, I'm doing it in real time. I'm changing the rendering, I'm changing the position. You're doing all of this so that you can optimize whether you're looking at muscle or soft tissue or the vessels or looking in the patient's lung. Again, you can change all the parameters. This is the reason I believe you need to do it interactively, because if someone just gave me a few images, it's not really going to be as good. Another example, this patient has a large mass in the left neck. There's some necrosis, there's vessel displacement. This is a patient with lymphoma. You can see the bulky adenopathy on the coronal views. The adenopathy extends into the supraclavicular zone. You can see relationships to the jugular vein and carotid arteries. And here's the rendering. Image on your left is classic volume rendering. Image on your right is cinematic rendering. Look at the soft tissues. Look at the vessels. Look at the parotid gland. You can see, as I do oblique views, really nicely defining the extent of tumor. Now, patients with lymphoma will be treated by chemotherapy, but this gives you a feel of how we can use the information if we were constructing radiation ports, if we were doing surgery or planning biopsy. All of this information really gives you a really good feel, not just that there's tumor present, but the orientation of the tumor and positioning of the tumor. Here you can see I'm looking in the top of the skull. You can see the circle of Willis. But again, the type of detail we're able to get. So again, just think about the imaging and what we're able to see, whether it's an anterior projection or a posterior projection. The interactivity becomes important, and you could send the referring clinician some videos or send static images. Here's a nice example of thymic hyperplasia in a patient with acromegaly. This would be a great thymus if you were 17 or 20, not if you're 40. Look at the volume rendering, classic volume rendering with grayscale or color, showing you the enlarged thymus and adjacent structures. But look how much better it is when you use the cinematic rendering. I'm showing you a little bit of the soft tissue of the enlarged thymus there. Here it is, a view from below, right? On one image, I'm showing you without the lung parenchyma. On the image on your right, I'm accentuating the parenchyma and the pulmonary vascularity. So you can see it's the same data set, the same volume. It's simply me choosing what I want to show. Look at the borders of the lung, and there's the thymus sitting there, and here it's sitting here as well. But again, the detail and information will vary depending on how you do the information. Now, we've done a lot of work with cardiac CT. Cinematic rendering is a promising method to enhance volumetric display of CT data and should be useful in diagnosis, treatment planning, surgical navigation, training, and patient management. And again, we looked at cardiac in this example. We've looked at things including ductus diverticulum and trying to avoid misinterpreting that as traumatic aortic injury. Things where vasculature needs to be visualized, or axial or even coronal and sagittal aren't as helpful as you want, the 3D configurations with cinematic can be very valuable. Here's a nice example showing you the coronary arteries with an occluded LAD. You can see the left ventricle, and I'll give you a few other images. One of the challenges, of course, there is the occlusion. You have to be very careful when you do cinematic rendering or volume rendering or any post-processing. You can create areas of stenosis or potentially hide areas of stenosis depending on how you do the rendering. So it really is interactive, but also you need to look at the data you start with. We don't look at 3D in a vacuum. We look at it with the source data as well. Again, as I mentioned previously, AI may be important in creating the optimal images for our patients. And again, here's just a few more views showing you the surface of the heart and the coronaries tracking down, including the occluded portion of the LAD, just really nicely shown. And here it is looking at the patient's MIP imaging, showing you that area of occlusion. And here it is when I'm tracking the LAD with curved planar reconstructions. So again, using all the information will be very valuable. Now, will that cinematic help the cardiac surgeon if they're going to do bypass or they're going to do a stent? That remains to be seen, but there does seem to be lots of optimism in that regard. Now, when you look at a case, here's a patient who's going to have a coronary artery fistula to pulmonary artery. When you look at the patient, you'd see the leads from the doing the cardiac CT. Image on the left was showing really nicely the muscle, the cartilage, the ribs in part. Then we hide the patient's muscle on the image on the right, and we show the ribs, the costal cartilage. Then we cut through, and now we're looking at the aorta, the branch vessels off the aorta. But here's this kind of conglomeration of vessels going from the pulmonary artery to the coronary artery to the aorta. This is the patient's fistula. These vessels are millimeter in size, but look how nicely they're shown distinctly on the cinematic rendering. And here's one more projection. It's really impressive, the lack of motion artifact, the ability to change the rendering parameters to be able to show even the tiniest of vessels and to show them with incredible detail, as in this example. Here's another case where we're looking from a sagittal view. You see the aorta, the arch, the branch vessels, left ventricle. Here's the left atrial appendage, which is lobulations, very nicely shown there as well. A really, really nice example. Here I'm coming down and targeting that left atrial appendage a little bit closer. You also see its relationship to the coronary arteries. Here's a patient with coarctation of the aorta, very nicely shown here past the left subclavian. There's a dilated left subclavian. There are multiple collaterals present, as there typically are in patients with coarctation of the aorta. And here's a range of projections showing you the dilated internal mammary arteries, the prominent intercostal arteries, and really nicely showing you the extent of the coarctation and what will need to be done. Whether a stent will be placed or they'll need to do an end-to-end repair will depend on what the surgeon thinks. That's a pretty tight stenosis, and the patient is, I think, in their 20s. But again, the cinematic rendering really gives you a good view. And here's the view from anteriorly, and I accentuated and left the sternum in to show you the dilated internal mammary arteries, which are a typical collateral pathway with coarctation. And here you can see the collaterals in the abdominal wall draining down and will attach to the inferior epigastric arteries eventually. And again, just a really, really nice example. The ability to look at everything and optimize visualization is indeed critical. Okay, very, very important. And here's the ability to change what you're looking at. Here I've gone inside the chest. Those are the internal mammary arteries. You can see they're dilated. But again, being able to select pieces of the volume. You don't always want to look at the entire volume. That kind of gives you maybe a gestalt as what you're looking at, but you really need to target down onto very specific areas to understand them better. Here's a nice example on the sagittal view of a penetrating ulcer descending thoracic aorta with an intramural hematoma. And here's that same set of images with the cinematic rendering. There's the ulceration, and you can see the dark area here, or here where I show the hematoma better. Again, the rendering technique becomes very critical in that regard. Yes, on the sagittals, without the cinematic rendering, we saw everything, but you can imagine why the cinematic is better, looking at the luminal diameter, looking at the entire volume, and helping the surgeon plan what they need to do. It also shows you how much information you have, depending how you vary the rendering technique. And here it is again from posterior. One of the nice things also about cinematic rendering and 3D in general, with things like bone removal and editing structures, you can create a range of perspectives that you never really look at. This perspective from posterior really gives the surgeon a real good perspective as to where that perforating ulcer is and that intramural hematoma. In this article by Rowe, we made the point that for complex anatomic configurations like thoracic aorta and pulmonary arteries, the lighting model and cinematic rendering adds even greater anatomic detail as demonstrated by the cases that I showed you. Now, other things. Here's a pericardial cyst. Pericardial cysts are typically right-sided, but they can be left-sided. This is an oblong one. Here it is with cinematic rendering. One of the things we know with cinematic rendering, when you use this type of volume display that I like, red, bright red, is water density. So one of the things it helps you do is determine density of tissue. Now, yes, you could see that on the axials, but you see it very nicely on the volume rendering on the left and the cinematic on the right. And really a nice visualization of that pericardial cyst with the cinematic rendering. And here it is from a sagittal perspective. Again, cutting through the chest wall, giving that oblique lateral projection becomes very, very valuable. And here's the view from below. Again, relationship to the lung, relationship to the cardiac structures, classic appearance for pericardial cyst. This was an interesting case. This was a patient, we were looking at the coronary arteries. It was a screening study, and you could see a linear broken structure in the patient's right ventricle, and that actually is a broken needle fragment in a patient who had a history of IV drug abuse. You do see it very nicely, I will have to admit, on the MIP imaging. Remember, MIP is really good for bright structures, and that metal is the brightest structure. Hard to localize it, but then when you do the cinematic rendering and you look inside the lumen, you can see how it's laying at the bottom of the patient's right ventricle. Again, the ability to look inside the chambers, really get a good look, whether it's for tumors or foreign bodies or thrombus. Cinematic rendering should be able to play a good job at that. And here's an example of a patient with a TAVR. Again, these are the same images, but here I'm making it very opaque. Here it's more transparent with that intraluminal view. Look how nicely you can see the TAVR and its orientation. And I'll just show you a series of images. This is the same exact case, obviously. All I'm doing is changing my rendering. Look how much more information you get as you change the rendering, both the muscles of the left ventricle, the positioning of the patient's TAVR. All of these things are done by simply changing the rendering parameters, and that's why interactivity becomes so critical. The case I just showed you takes advantage of what we call black blood, a way of looking into the lumen. It's a really nice way of doing things, and we use it routinely. Here's from the article, just a really nice example of black blood imaging. It's very important to develop the presets for that. Here's a patient with having chest pain, has an AVR in place, and there's a clot, it looks like, on the aortic valve. Here it is from an oblique view, and here it is with the cinematic rendering. So again, being able to look at the valve leaflets, being able to look intraluminal, whether it's in the aorta or the left ventricle or any chamber, becomes very, very important. Another example, here's a patient with a clot in the left atrium and a clot in the SMA, and the patient has a Watchman device in place, which is put in the left atrial appendage to occlude it so it doesn't shower emboli. You can see, look at that thrombus there. Now, of course, you could say, how I know it's not a myxoma. It's a very tiny stalk going right to the patient's Watchman device. Beautifully shown on those endoluminal views, and with the view with more opacity of the patient's blood, which is the lower image. Again, it will be up to you what image you like. I like both of them, but I really love that intraluminal view, and I think there's much more we can do with that we haven't done to date. Just a really nice example. And there's that thrombus shown from below. And here it is with a more standard, where the blood is bright, and you see the filling defect, as opposed to the black blood, where the blood becomes transparent, and you use the density of the blood to make it go away. I think we're also going to see lots of work done with devices. What devices are in this patient? Well, you see something in the aortic valve, you see something in the mitral valve, and it looks like there's an occluder between the left atrium and the right atrium. And here it is on the MIP imaging, so you see the three devices present. And here it is on the cinematic. Really nicely showing you the three devices, showing your relationship to the vessels. Here it is intraluminal. And I think, in my mind, the ability to use this information to look at different valves, different cardiac surgeries will become very important in the future. And just a really, really nice example here of a mitral valve replacement, an ASD closure device, and an aortic valve. So again, very nicely shown. Now let's go from here into the abdomen. And what I want to speak about is how we use these applications in oncology and far beyond oncology. So let's do this. Let's stop here and come back in, let's say, 15 minutes. Everyone get a drink, and we'll see you in a few minutes. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.